We have a really great speaker, Lara Dunn, for head and neck oncology, where we are with immunotherapy. And then we will follow that with a discussion about where we are with immune therapy in colon cancer, and then two more debates about how long we should treat patients, and then if efficacy of immune checkpoint blockade is better after surgery or before surgery. So to kick this whole group off, Dr. Dunn, thank you very much for telling us the updates in head and neck oncology.
Thank you, Mike, for inviting me. All right, so currently, as Dr. McBride mentioned, there are two PD-1 inhibitors that are FDA approved for the treatment of recurrent and or metastatic head and neck squamous cell carcinoma. The first is Pembrolizumab and the second is nivolumab. In 2016, the FDA approved these agents in the platinum-refractory setting. Pembrolizumab was approved based on a phase 1b trial, KEYNOTE-012, and nivolumab was approved based on a randomized phase 3 trial, CheckMate 141. Just in June of this year, Pembrolizumab was approved in the first-line recurrent metastatic setting in patients who did not need to be platinum refractory, and this was based on KEYNOTE-048. Pembrolizumab monotherapy was approved for patients whose tumors had a combined positive score of equal or greater than 1. The combined positive score is the number of PD-L1 positive cells that includes not only tumor cells but also lymphocytes and macrophages in the tumor microenvironment, divided by the total number of tumor cells times 100. And then pembrolizumab with chemotherapy, and the chemotherapy was a platinum agent, either cisplatin or carboplatin, and 5-FU, was approved in the first line for the total population regardless of CPS. This is CheckMate 141, which is the phase 3 trial that randomized patients with platinum refractory recurrent metastatic disease in a 2-to-1 fashion to nivolumab versus investigator's choice chemotherapy. And as you can see in the first Kaplan-Meier curve, that the 1-year overall survival rate doubled for the group that received nivolumab compared to investigator's choice chemotherapy, and there was no difference in progression-free survival. So from this study, nivolumab was the first agent that showed a significant improvement in survival after progression on platinum-based therapy, and that led to nivolumab's approval in the platinum refractory setting. KEYNOTE-012 is a phase 1b study of pembrolizumab in the platinum refractory setting. The overall response rate was about 18%. It was slightly higher in those with HPV-positive disease as compared to those with HPV-negative disease. You can see here from the waterfall plot that in those who did respond, the responses were fairly deep. And from the spider plot, in those who responded, the responses were very durable. It was shown that pembrolizumab led to robust, durable anti-tumor activity in those who responded, and this did lead to pembrolizumab's approval in the platinum refractory setting. KEYNOTE-040 mirrored CheckMate 141. This is a phase 3 trial randomizing patients in a 1-to-1 fashion to receive pembrolizumab versus investigator's choice chemotherapy. And based on the intention to treat analysis, the result was that it was a near miss in terms of pembrolizumab providing an overall survival benefit compared to investigator's choice. However, when they did subset analysis looking at tumors with high PD-L1 expression or a TPS of greater than 50, it is shown that we could select for patients who would respond to pembrolizumab and have an overall survival advantage. So, based on this intention to treat analysis, there was a near miss in statistically significant improvement in overall survival with pembrolizumab, and it did show that high PD-L1 expression correlated with improved survival. Following studies in the platinum refractory setting, the thought was that there would be potential benefit with checkpoint blockade in the frontline setting, especially in certain settings. One reason is that high PD-L1 expression has been associated with higher response, as seen from KEYNOTE-040, and also The thought was to combine PD-1 inhibition with chemotherapy, as done in lung cancer, which showed promise. And so this was the first study, Keynote-048, to test or evaluate and show a benefit of PD-1 inhibition in the first line or frontline setting for recurrent metastatic disease. This was a fairly complicated design where patients were randomized in a 1-to-1-to-1 fashion to either pembrolizumab monotherapy to pembrolizumab with chemotherapy, and chemotherapy included cisplatin or carboplatin with 5-fluorouracil, or our standard of care frontline regimen, which is the extreme regimen, which consists of a platinum agent, cisplatin or carboplatin, 5-fluorouracil, as well as the anti-EGFR antibody cetuximab. Comparisons were done between pembrolizumab monotherapy and extreme only for patients with a CPS of 1 or greater. And then a second comparison was done evaluating pembrolizumab with chemotherapy versus extreme in the total population. And all the endpoints in this study were analyzed by 3 cohorts based on CPS. The first was CPS greater than or equal to 20, the second was CPS equal to or greater than 1, and the third included the total population. This is overall survival, which was the primary endpoint. And you can see here that in the first graph, in CPS of greater than or equal to 20, patients who received pembrolizumab alone versus standard of care with extreme did experience an overall survival benefit. The median overall survival was over 14 months compared to 10 months in the group that got pembrolizumab compared to standard of care. And then for the group with CPS of greater than or equal to 1, there was still an overall survival benefit shown in the group that got pembrolizumab alone compared to standard of care. It was just not as significant as compared to the group with a CPS of greater than or equal to 20. And then you can see for the total population where they looked at pembrolizumab plus chemo versus extreme, there was overall survival benefit in those who got pembro up front. And so the conclusions from Keynote-048 were that an overall survival benefit was shown in pembrolizumab alone in groups with a CPS of greater than or equal to 1, as well as pembrolizumab with the addition of chemotherapy in the total population regardless of CPS in the tumor. There was no benefit in progression-free survival with pembrolizumab alone or pembrolizumab plus chemo over standard of care extreme, and the response rates were worse with pembrolizumab alone compared to standard of care extreme or pembrolizumab with chemotherapy, which were about equivalent. So after these trials in the platinum-refractory as well as a frontline setting for recurrent metastatic disease, several questions arose, and I've highlighted the ones that I think are the most important. And the first is, what is the role of pembrolizumab monotherapy versus pembrolizumab plus chemotherapy in those with a CPS of greater than or equal to 1? The second is the overall survival benefit only related to actually receiving a checkpoint inhibitor, or does the line of therapy actually matter? The third is, will novel combinations improve the percentage of patients with head and neck squamous cell carcinoma who respond to checkpoint blockade? And then moving to the locally advanced setting, the questions we have are, should checkpoint blockade be integrated into definitive treatment with surgery and or chemoradiation? The second is, are checkpoint inhibitors effective radiosensitizing agents? And the third is immune-associated toxicity enhanced when given with radiation? So to address the first question, what is the role of pembrolizumab monotherapy versus pembrolizumab plus chemotherapy in those with a CPS of greater than or equal to 1? the question that we need to answer is, what is the efficacy of Pembro alone and Pembro plus chemo in the group with a CPS of 1 to 19%? Because in the study, it only showed the results for those with CPS greater than or equal to 1, and we don't know what proportion of those patients had a CPS of greater than or equal to 20, and if those patients significantly influence the statistically significant overall survival benefit. Another question that would be important to know is that given the low overall response rate of pembrolizumab alone, should pembrolizumab plus chemo, which has an equivalent response, response rate to extreme, be given in symptomatic patients with large disease burdens or patients with disease in concerning locations. And so you can see that the response rate of pembrolizumab monotherapy in this study was about 17% compared to 35 to 40% in those groups who received chemotherapy. And so my thought would be, yes, I do tend to give Pembro plus chemotherapy up front in patients with large burden of disease who are symptomatic, or patients with disease in concerning locations such as regional recurrences near the airway or the carotid arteries or near the spine. The second question is the overall survival benefit only related to actually receiving a checkpoint inhibitor? So what I'm asking is the maximum overall survival benefit of pembrolizumab derived when administered only in the first-line setting? After the results from Keynote 040 came out, the authors wanted to figure out why there was a near miss in terms of statistically significant survival benefit in the group that got pembrolizumab in the platinum-refractory setting. So they divided the group that got investigators' choice chemotherapy based on subsequent therapy, including subsequent checkpoint inhibition. And you can see that green line here in the upper graph shows those that got subsequent checkpoint inhibitor versus those who didn't. And you can see that there was a survival advantage just by getting checkpoint inhibitor in subsequent lines. And so the second graph, or the lower graph, looks at the survival analysis, which is censored at the time of subsequent therapy. And you can see here that in this non-intention to treat analysis, there is a survival benefit with pembrolizumab. So this does suggest that there is an overall survival benefit to receiving a PD-1 inhibitor, although it may not matter which line the PD-1 inhibitor is received in. And also to address the same question, in Keynote 048, only 25% of patients randomized to extreme, or the standard of care arm, received checkpoint inhibitor therapy, and this is because this study occurred outside of the US, where PD-1 inhibition has not been approved in certain countries. And we saw in this study that the median overall survival of extreme arm was similar to what was seen in the prior study that was published over 10 years ago, establishing extreme as a standard of care, which was around 10 months. So a question I have is, considering the low overall response rate, would you ever use extreme in the first line, and especially in symptomatic patients, given that it's not clear which line you need to give checkpoint inhibitor to get the overall survival advantage? And my answer to this is yes, especially in certain subsites like oral cavity cancer, where the response rates to cetuximab is actually very high. The last question for the recurrent metastatic setting is, will novel combinations improve the percentage of patients with head and neck cancer who respond as checkpoint blockade? So the first couple of combinations with nivolumab and liraglutide, which is an anti-KIR antibody, and then pembrolizumab with epacadostat, which is an IDO inhibitor, in the phase 1/2 trials, the overall response rates were promising. We did see a signal of activity with these combinations. However, in subsequent evaluations, they were not seen as promising, or the results were not as exciting. The last combination I have here with pembrolizumab and lenvatinib, which is a multi-targeted TKI that specifically targets VEGF, had a really outstanding response rate in a phase 1/2 trial of 36%. It's now being tested in a randomized phase 2 study, and we're very optimistic about this combination in head and neck squamous cell carcinoma. I'm going to turn to questions in the locally advanced setting. And the first question is, should checkpoint blockade be integrated into definitive treatment, either concurrently or sequentially? This is different than the question that Dr. McBride addressed, given that we're looking at definitive or curative-based treatment as opposed to SBRT, palliative radiation. And so this study, RTOG Foundation 3504, took locally advanced head and neck cancers and randomized, these patients were, sequentially, not randomized, to 3 arms with 10 patients in each arm. Arm 1 and 2 looked at chemoradiation with concurrent cisplatin, just different doses of cisplatin, with nivolumab. Arm 3 looked at chemoradiation with cetuximab and nivolumab. And Arm 4 was standard of care chemoradiation with adjuvant nivolumab. Based on early results from Arm 1 and Arm 2, 40% of these patients had an immune-related toxicity. So it does make us question, our immune-related toxicities increased with PD-1 inhibitors when added to definitive radiation. And then in Arm 3, out of the 10 patients, 8 completed treatment, 2 did not complete radiation treatment. So again, it makes us question if there's enhanced toxicity when PD-1 inhibitors are added to radiation. There are several ongoing studies that will address these questions that are important in the locally advanced setting. The questions include, should checkpoint blockade be integrated into definitive treatment? Are checkpoint inhibitors effective radiosensitizing agents? Can they replace cisplatin or other potent cytotoxic agents that we know to sensitize tumors to the effects of radiation? And again, is immune-associated toxicity enhanced when given with radiation? Javelin was a study that we conducted here. It was a randomized phase 3 study of patients with locally advanced head and neck cancer treated with chemoradiation, specifically concurrent high-dose cisplatin, and patients were randomized to receive avelumab, which is a PD-L1 inhibitor. NRG-HN001 is a phase 1 study of postoperative chemoradiation with cisplatin and pembrolizumab. It's specifically looking at safety. RTOG-0023 is a phase 3 study of postoperative chemoradiation with cisplatin and a pembrolizumab arm that's looking at efficacy as well as safety. NRG-HN004 is a phase 1 safety run-in followed by a randomized 2/3 study of radiation with either cetuximab or durvalumab, a PD-L1 inhibitor, for patients who are elderly and cisplatin ineligible. And then NRG-HN005 is a phase 3 study in patients with HPV-positive oropharynx cancer, and there's 3 arms. None are standard arms. The first arm is 70 gray, which is a standard amount of radiation, but given with 6 fractions a week over 6 weeks with cisplatin. The second arm is 60 gray in 6 weeks with cisplatin. And then the third arm is a very bold arm where they're not only dose-reducing radiation from 70 gray to 60 gray in 5 weeks, but they're replacing cisplatin with nivolumab. And it's really unclear if PD-1 inhibitors are effective or potent radiosensitizing agents compared to cytotoxic chemotherapy such as cisplatin. So thank you.
Time for one quick question before we move on to the next talk. I guess I have a really quick one. So we know that PD-1 works in cutaneous squamous cell carcinoma, and this is head and neck squamous cell. Why is it much more effective in cutaneous squamous cell carcinoma compared to head and neck squamous cell carcinoma? I know that's probably not an easy answer, but what do we think about that?
So I think the simple answer is that the tumor mutational burden is much lower in head and neck squamous cell carcinoma compared to cutaneous squamous cell carcinoma. Since cutaneous squamous cell carcinoma tends to be a disease driven by ultraviolet radiation as a risk factor, these tend to be extremely hypermutated tumors, even more hypermutated than melanoma. And so that's the thought as to why they are so responsive to PD-1 inhibition compared to the lower mutation burden tumors seen in mucosal squamous cell carcinomas.
Great, thank you very much. I'm sorry, Omar, we're just a little over time, so we'll save it, if it's okay, for the panel discussion thereafter.